Hello and welcome to the Mastering Blood Sugar podcast. It's Dr. Brian Mowll, and I have with me today a guest that I'm very excited to talk to, someone that you're going to learn a ton from. His name is Dr. Robert Lufkin, and Dr. Lufkin has a background in radiology. He taught at various medical schools, including UCLA and now USC. And he has a book that I love the title of this. When I first saw it, I thought it was lies that I learned in medical school, but it's actually lies that I taught in medical school. So we're going to talk to Dr. Lufkin about some of the things that he used to teach and how his perspective has changed over the years, and hopefully maybe shortcut that learning curve for a lot of you listening. So Dr. Lufkin, welcome to Mastering Blood Sugar. Good to have you here.
Hey.
Great. So, hey, when did
Brian,
you write
sorry, the mic cut out for a second. Hey, Brian, it's great to be here. Thank you.
No problem. Hey, how long ago did you write the book? I know it's been out for a few years now. When did you release it?
Actually, the book came out June 2024, so it's been just out a few months.
Oh, wow. Okay. For some reason, I thought that it had been out longer. So that's fantastic. This is a relatively new book and has a lot of great content in there. I love the way it's organized, sort of highlighting some of these things that you used to teach and how your perspective on them has changed. What was your main motivation to get this information out there?
Yeah, I mean, thanks. That's a great question. Let me say, as a member, as a lifelong medical school professor, I'm part of the problem of Western medicine, and the book is critical of Western or allopathic medicine, really. But I have to say, I'm still practicing that, and Western medicine really revolutionized our lives in the 20th century largely through infectious disease and public health measures. It truly made the world a better place. The pills and surgeries were nothing short of magical. And even today, if I get hit by a car, I'm going to want Western medicine to, get a blood transfusion. I'm going to want my bones set. I want my spleen removed, that sort of thing. But the problem is, and what this book is all about, is in the 21st century, we are all on a global scale facing literally a tsunami of what are called chronic diseases. And these include everything from obesity, diabetes, cancer, heart disease, Alzheimer's disease, hypertension, even mental illness. And these diseases are present in numbers that while they were around in the 20th century, they're nowhere near they are today. And the real problem is when Western medicine takes the same pills and surgeries that were so effective against the diseases of the 20th century and applies them to these chronic diseases, they oftentimes work in controlling the symptoms, but in most cases they don't get to what is the root cause. And that means that these diseases continue to progress and progress and progress, even though the symptoms may be controlled. And I learned this the hard way when I came down with 4 of those diseases. And I went to my doctor and I was prescribed 4 prescription medications for them. And, it was all new to me. And I asked them and I said, so, what about lifestyle? Does that really work? And they go, nah, don't bother. You're going to be stuck with these diseases for the rest of your life. And, so get used to it. That was the advice I was given. And at that point, it really made me begin to question what I knew, what I was teaching, and what many of my colleagues are still teaching about the way these diseases work. And long story short, I changed my lifestyle with some relatively simple things and was able to reverse these 4 chronic diseases. And now I've made it my mission to get this message out to other people, to let them take back their health so that they don't make the same mistakes that I did.
So many of us have had a personal experience, and I think, as physician, you've spent so much time studying medicine, studying science, studying maybe not health, but the disease side of health for sure. But oftentimes it takes a personal experience to shake up how we think about things, to force us to look at things maybe from a different perspective. What was it for you? So was it just the words of your personal physician saying you're going to have to probably live with this, that you said, that's not okay, I got to find a different path? Or did someone introduce you to, some other things? What was it that sort of was that catalyst for you to start down a different path?
Well, as a physician, I knew what these diseases were like. I knew the roadmap and what the future held. If I continued to take the pills and these diseases continued to progress, it wasn't going to end well. And at the time, I had, as my two young daughters we talked about before, were in elementary school, and I wanted to live to see them graduate from high school. So it was. I'd like to say, hey, I wanted to make the world a better place, but no, not really. It was out of self-interest, like motivates most of us at our core, our family, our loved ones, and that was the motivation for me. And the deeper I began to look, I realized, wow, we're really getting things wrong, and there's some big mistakes here that really make a difference in people's lives that most of my colleagues weren't aware of at the time, and I certainly wasn't aware of either.
Yeah, for sure. So let's dive into some of that. And we are a diabetes-based, blood sugar-based podcast. So let me start with that. What was the biggest lie, or what was the biggest misconception? What was something that you felt like you were teaching about diabetes, metabolic health, blood sugar, that now you look at from a completely different perspective? Like you feel like, wow, I can't believe, that's what I was teaching, when now I see things so differently.
Well, diabetes, and when we say diabetes, we're talking largely about type 2 diabetes right now, which is over 90% of what people have. And this is exploding like all these other chronic diseases in these epidemic proportions. And what really, and I have full disclosure, one of the diseases I had was type 2 diabetes, was pre-diabetes, but like the other four or the other three, I was able to reverse this with lifestyle. So there was no further need for medications. But with type 2 diabetes, it's interesting. It's insulin resistance, which is type 2 diabetes, is really the root cause for almost all the diseases that I mentioned, or a large contributing factor. Type 2 diabetes is related to obesity, certainly. It's a major risk factor for cardiovascular disease. Cancer is a major risk factor for. Alzheimer's disease, because of its dependence on glucose metabolism, is referred to as type 3 diabetes in some circles. And mental illness is also tied to type 2 diabetes. So it's really foundational, and insulin resistance is a main driver. The problem with type 2 diabetes is that it is, as I'm sure you've talked about this with your audience before, that it's a disease of the way we handle carbohydrates. And insulin is a response to carbohydrates. And when we eat a lot of carbohydrates, our insulin goes up, and we build a sort of a resistance to it and require more and more insulin. And this is what's insulin resistance. And the problem is, insulin, although it's life-saving as far as blood sugar control, it has negative effects as far as cancer, as far as these other things. So high insulin levels in themselves are deleterious. So the problem is, here you have a disease that's caused by eating too many carbohydrates. And just to review, the three food groups, the three macronutrients, of course, are fat and protein, which are required. If we don't eat those, we die. They're required for life. Interestingly, carbohydrates, the one that drives insulin and drives diabetes, are not required for life. In fact, there are populations of humans that do very well on very low amounts of carbohydrates. So here you have a disease that's driven by a certain food group that's not required. So it would make sense that you would treat it by just, lowering your carbohydrate intake. But no, the leading institutions, the leading medical institutions, medical schools, and American Diabetes Association, our trusted sources, don't really recommend that as a frontline approach. Instead, they control it with drugs, metformin, and then on eventually to insulin. And I'm not saying don't take drugs don't take drugs that your doctor recommends at least. Never discontinue drugs without involving your doctor. But the problem with type 2 diabetes is when we control it with insulin, it's a progressive disease. In other words, the insulin keeps us from dying of super high blood sugar levels. But for most of the side effects and the progression of type 2 diabetes, they don't really slow down. What are the side effects? Well, I'm sure you've talked about this. Type 2 diabetes is the number one cause of amputations, surgical amputations in the United States. It's the number one cause of renal failure and dialysis, kidney failure. It's the number one cause of retinal blindness, and on and on and on. So if I treat type 2 diabetes with these medications and control the symptoms, I will still have a chronic progressive disease that will eventually kill me. Well, there's the other option, of course, is what you do in your programs, and is to help people understand that carbohydrates are causing the type 2 diabetes. And it's been shown that in controlled prospective studies that by limiting carbohydrate intake, by diet, essentially this lifestyle approach alone, we can reverse type 2 diabetes in the majority of patients. And what happens though? I mean, there's a pill or there's lifestyle, but with a pill, it's a chronic progressive disease. It gets worse and worse and worse. Interestingly, when we reverse it with lifestyle, it stops. In the majority of cases, it no longer progresses and even reverses. So, why isn't that message being communicated more and more to people? Why isn't that getting out there? That's a huge wake-up call about type 2 diabetes for me.
It really is. And I always find it amazing that it's such a simple message, but it doesn't seem to be the one that gets passed along. I've had many clients or patients tell me that they told their doctor what they were doing. The doctor saw the results on lab findings or imaging or what have you, and they said, hey, whatever you're doing, keep doing it. But rarely ever said, hey, tell me what you're doing so I can go tell all my other patients, right?
Yeah.
And that's always been surprising to me. So, I think it's just that there's a comfort zone, and, we get into this comfort zone of going into the office and doing what we do. And it takes sometimes, like we said earlier, personal experience or some sort of wake up to change our perspective on things. But I am happy to see that, like, even the American Diabetes Association is at least opened to low-carb ketogenic diets and so forth. They've sort of moved away from even making a dietary recommendation now. It's kind of that it's to be very personalized, which I think is probably a good approach. So,
I mean, we still see
yeah, please
take the other side of that. We still see on their website.
Okay.
Recipes that are promoted by the American Diabetic Association with high levels of carbohydrates, with sugar in them. And their recommendation is to, quote, cover it with insulin, which is, you increase your insulin dose slightly. And it's interesting, you go, why are they doing that? But I posted about this on social media. Like, one of those particular ads had their sponsor right next to it, and their sponsor was DaVita Corporation for this ad that recommends large amounts of sugar that will eventually drive patients, the diabetes patients, to the complications, which the number one complication is renal failure. DaVita Corporation, of course, is one of the largest dialysis companies that makes renal failure equipment. So it's, yeah, I mean, the other thing that blew me away about, or changed my thinking about disease in writing this book, especially about diabetes, was that I used to think of diseases as sort of binary. You know, you either had them or you didn't have them, right? And I now, after some interesting studies with diabetes, I don't think it's that way. In other words, diabetes, but also the other diseases I mentioned, I believe don't begin when the doctor diagnoses them. In other words, the doctor may say, "Oh, your blood sugar is over this point. You now have diabetes, and a week ago it wasn't, so you don't." Or, "Oh, you forgot your keys. Well, now you have Alzheimer's disease." And I'm not making light of any of these diseases, but I want to make the point that they don't, in my opinion, and the evidence is very strong, they don't begin when the doctor diagnoses them, and they begin actually weeks to decades before the doctor diagnoses them. And if we wait until the doctor diagnoses one of these diseases before we start making lifestyle changes, we're missing a tremendous opportunity for benefit, prevention, pushing it off further down the line. And type 2 diabetes, I used to think, insulin resistance, I used to think this was something that, some people get, some people don't get. But there's some great studies we talk about in the book from using the Framingham data and large populations of adult Americans, non-diabetic adult Americans. If you look at their blood tests, the hemoglobin A1C, which is one of the major diagnostic criteria for type 2 diabetes, when it gets above a certain point, you cross a threshold and the doctor says, "Oh, you have prediabetes," and then, "Oh, you have diabetes." And before that, you don't. Well, interesting thing happens in this non-diabetic adult population. What we see is that the hemoglobin A1C levels, or insulin resistance, increases with age. What does that mean? Well, that means if I live long enough, it means that type 2 diabetes for many people, arguably maybe even most people, is like gray hair. In other words, if I don't die of something else first, I will eventually get type 2 diabetes, because my A1C is going up and up and up. So what's the message there? Well, I should have a healthy lifestyle like you're doing in your program, whether I have type 2 diabetes or not, because it's going to help for every single one of those chronic diseases. And it's going to push that, if not the gray hair back, it'll push the type 2 diabetes back a little bit.
That is such a great point. I've long argued that there really is no such thing as prediabetes, and I'm not the only one to do that, of course, because it's really all the same underlying mechanism. And I think people get confused, like the thresholds for diagnosis are often tied to prescribing, right? So it's like, or to insurance, benefits and so forth. So it's like, it has to get to this point so I can diagnose it. And then it's this, series of treatment, which is usually one medication after another. When you're looking at trying to fix the, functional causes, the underlying drivers, you realize it's all just a spectrum. It's it's shades of gray. And when you are looking at a fasting blood sugar of 99 versus 110 versus 130, those are three different things medically, but really they're just all variations of the same thing, which is what you've talked about, this underlying insulin resistance and metabolic dysfunction, which ultimately drives type 2 diabetes and all the complications that you so eloquently talked about. So I think that's a big difference in sort of medical care and treatment from looking at this and saying, how can we actually solve this problem rather than just manage it or treat it? And I'm sure that's probably something that, you've come around on as well. I would imagine you maybe see things a little bit differently because the way you described it is it's not just we have the disease or we don't, right? It's not do we have the diagnosis yet or not? It's really what's going on under the surface. Are we really healthy or not? I think, or how healthy are we? How's our body functioning? We talked earlier about some imaging tests, and I want to talk about those again a little bit later, because I think one of the ways that we can assess our level of metabolic health is by digging a little bit deeper, maybe looking closer at some lab tests, and imaging is another thing that I think very few people do. And you have a background, of course, in imaging, so I'd love to get some more information about that. I'm just kind of forecasting what we're going to talk about in a few minutes, but before we do that, I'd love for you just to uncover maybe a few other of these lies that you taught in medical school that maybe you've changed your mind on. And one of them, I'll stop monopolizing all the airtime here in a second, but one of them is about fat and cholesterol, because you talked about the benefits of a low-carb diet. Well, that means if we're not going to eat a lot of carbs, protein's important, but we've also got to get some fuel, so we're probably going to eat more fat. And I think that's one of the things that some doctors will push back on is, you've got to watch your saturated fat. I don't know if a high-fat diet's really a good idea. Doesn't that cause fat in the liver and other organs, which we'll get into with the imaging? So how has your mind changed on those areas?
Yeah, I think the teaching since the 1950s with Ansel Keys and everything was that heart disease was caused by cholesterol in the diet and saturated fat, and that's formed the foundation for our public health recommendations, our food pyramid, everything of what people eat, and it's really in our minds. We still have egg white omelets available at restaurants if you go to it, but the thinking is now changing. Even the most conservative medical establishments now agree that dietary cholesterol does not affect serum cholesterol. So, eat as many eggs as you want. They're probably one of the healthiest things you could eat, really. So don't worry about cholesterol, which eggs have a high cholesterol in the yolk. So dietary cholesterol is not the problem. There's still a lot of debate about LDL cholesterol and saturated fat and how this contributes to heart disease. One school of thought is back in the beginning of the 20th century, they looked at blood vessels with plaques in them, and they showed cholesterol in the plaques and fat in these fatty plaques in these heart atherosclerotic plaques, and it caused heart attacks and these heart disease. And they figured, the more LDL, saturated fat, cholesterol I have in my bloodstream, the more likely I am to get these plaques. And as it turns out, it's not quite that clear. I think there's now a school of thought that's showing that while LDL cholesterol is necessary for the plaques to form, they're not necessarily causative. In other words, they're part of the repair mechanism of our body. It takes cholesterol to make the plaques appear, but they're not causing the plaques in itself. What's the evidence of that? Well, there are causes of heart disease that don't involve cholesterol at all. For example, one of the biggest causes of heart disease and heart attack is smoking. Smoking causes plaques, which contain cholesterol, but smoking in itself has no cholesterol in it itself. Then there's arguments about, most people who come into the hospital for a heart attack, when you check their serum cholesterol or LDL cholesterol, it's not elevated. So most people who come in for heart attacks don't have high cholesterol. And there's the whole statin industry, which is a drug, of course, that's prescribed to lower serum cholesterol. And it showed that it does actually improve the chance of dying from heart attacks by a very small amount, like about 1%. But hey, heart disease is the number one killer. So even a 1% improvement, I'll take that. So why not take a statin? Well, One, they have a lot of side effects. Lowering cholesterol. Cholesterol is important for our brain. It's important for our hormones and many other, all our cell membranes. So lowering cholesterol may not be a healthy thing. And in fact, now when we look at people on statins, what are in these large studies that have come out recently that look at what are called all-cause mortality, which all causes of death. If you look at people on statins, they have 1% fewer heart attacks than people who aren't on statins. Hey, great, I'll take that. But interestingly, in several of these studies, the overall death rate wasn't any different between people on statins and not on statins. Well, what does that mean? The people who were on statins, they had fewer heart attacks, but they died more often of other things. Well, that's weird. What are the things that they die of? Well, things like traffic accidents, suicides, things that might involve mental actions. The point is that lowering cholesterol, the benefit for heart disease may not be worth the risk. And we can look at things like hazard ratios, which tell how much some behavior contributes to a heart attack. And LDL cholesterol is very low on the hazard risk scale. Things like smoking are much higher. And type 2 diabetes is much, much higher. Metabolic disease, HDL cholesterol, triglycerides, which are measures of metabolic disease and insulin resistance, are much more risk factor for heart attack. What does that mean? I'm much more likely to increase my chances of dying of a heart attack by eating a sugar donut than I am by eating some saturated fat in a steak or something like that.
That's interesting. I'm putting you on the spot here a little bit, and I don't know if you have the answer to this question or not, but as a radiologist, you've certainly studied imaging a lot. You've done a lot of imaging. Is there a correlation or a strong correlation between LDL number, LDL cholesterol, LDL-C, or LDL particle number, or ApoB, or any of these ways of measuring atherogenic lipoproteins, and things like arterial plaque that you can image, whether it's either through calcium score or other imaging?
Yeah, there's the part of the risk factor. Some of the papers that do the risk factor are basing it on actual heart attacks. Others are basing it on basic asymptomatic calcifications in the arteries. And the same things apply across there. In other words, LDL cholesterol has a small risk factor. Smoking is a very large risk factor. Type 2 diabetes, insulin resistance, metabolic disease is a very large risk factor. So the same thing sort of applies to the imaging, in my experience.
And how much do you think saturated fat is a factor here? So let's say that all things equal, maybe it's better off to have a lower LDL than a higher LDL if you're metabolically healthy and everything. And I'm not talking about using statins to get there. I'm just saying in a vacuum, having a lower LDL is maybe a little bit safer. How much do saturated fats play a role? I've seen information that says that they will raise LDL, but maybe the large buoyant LDL, and maybe they don't affect liver clearance of LDL particles. So your small dense particles are going to be lower, which is a lower risk factor. Do you have an opinion there around saturated fat and LDL and heart risk?
And it's really just an opinion, which is all anybody has. The science really isn't settled on this. There's a lot of difference of opinion, but I believe that saturated fat is not the problem with heart disease. The bigger problem is metabolic dysfunction and insulin resistance. So I think saturated, because as you know, when we switch our diet of the three food groups, right, fats, proteins, and carbohydrates, we kind of keep proteins constant for a number of reasons in the middle. We don't change it up that much. So if you're going to go to a low carb diet, you have to go to a higher fat diet in most cases. So what's the trade-off there? Well, there's a group of fats that are called seed oils that are industrial they were originally developed as machine lubricants for possibly German U-boats in World War One, and then Procter and Gamble discovered that that people would actually eat them, and they marketed it as a product called Crisco to replace lard. And famously, the Procter and Gamble contributed millions of dollars to a struggling scientific organization called the American Heart Association in the 50s, which now recommends seed oils and Crisco-like products on their website as being heart healthy, because they actually do lower LDL slightly in consuming these. But the problem is they also are very oxidative. So they drive oxidation. They actually drive insulin resistance, in my opinion, as well. So they're replacing saturated fats with these unhealthy seed oils is a mistake. Now, there are other oils like avocado oil, coconut oil, olive oil, which are healthy oils that don't have this oxidative problem that the seed oils have. So we can use those. But I believe the saturated fat is healthy, and it will raise your LDL, but in my opinion, I don't think that's a problem.
So if somebody was going to eat a low carb diet, maybe ketogenic or at least very low carb, and they were putting together their meal plan, and they had a choice between sort of a ribeye, sort of fatty cut of steak, or a leaner cut of steak, like a strip or something like that. And let's say they were going to eat some vegetables on the side anyway. Would it be better to eat the fatty cut of steak or a leaner steak and then get some of the oils from things like olive oil and avocado oil? Or do you think it doesn't matter that much one way or the other?
No, it's a great question. And full disclosure, I was raised, my mom was a dietitian. So okay. I was raised with the idea that somehow food mattered to our health.
Yeah.
Unfortunately, I was also the dietary wisdom from the American Dietetic Association back then, and still to this day, is that fat is harmful. Carbohydrates are good and healthy. You want to substitute carbs for fat. So we would, as a family, we would carve, if we got a steak somewhere, we would carve the fat off the steak and make sure we didn't eat it. We would eat butter. Instead of eating butter, we'd eat margarine, which is full of trans fats and seed oils, basically, which is horrible for your health. But and then we ate low fat yogurt, low fat this, low fat that, which just means the healthy good fats are taken out and it's substituted with carbohydrates, largely sugar. So I know that story. I lived it. I don't believe it now. In fact, I think the fat is healthy, and I'm more likely to be harmed by the carbohydrates in the food I eat or the seed oils in the food I eat than the healthy saturated fat on the beef. Now, there's still a whole history on, assuming you're a meat eater. If you're a vegan, which I was for 10 years, it's a whole different story. But as far as eating the meat, even the meat, of course, it should be regeneratively raised, because if you raise animals in a situation where they're fed a lot of omega-6 fatty acids in soybeans and corn, which much animals, our livestock is fed today, it distorts the profiles in the fat, and it's actually much worse than a healthier beef is too. So there's a lot of nuances on this. But to answer your question, yeah, I think saturated fat is healthier than eating seed oils or carbohydrates, refined carbohydrates, sugar, starches, all those things.
Absolutely. Okay. So you were a vegan for 10 years, which I lasted about 3, but I did raw food for a little while, and then was a vegan for probably about 3, mostly vegetarian for a number of years after that. But so as a recovering vegan, what are some of the things that, well, again, I'll just ask the same question I asked earlier. Was it the same 4 conditions that led you to change your diet, or did that happen over time? And what have you learned about yourself by transitioning your diet there?
I think it's good to try different diets, like you say. I love you. You were raw for a while, and all these things. It's good. It's good. We all, because what we eat now has become so politicized. Like, even driving a Tesla is a problem now. So with some people, but it, I have to say, I love my vegan friends. I love my carnivore friends. I just wish they would talk more. When I was a vegan, I realized it's challenging to be healthy as a vegan. I mean, as a carnivore, you just eat meat and you're healthy. You don't have to eat anything else and you're pretty much healthy. As a vegan, though, because of the nature of the protein in plants, and the nutrients that are in plant sources, we have to really be careful about missing out on certain nutrients. And so it just requires more attention than doing that. But I was a junk food vegan, so I would eat anything that didn't have meat in it. So it's like, oh, it's rice, great, give it to me, or I would eat potato chips and anything that didn't have meat in it, which was really, really bad. And then, for a number of reasons, I switched to a more the diet I follow today. But I think, to your point, we all have to find a way of eating that works for us, and we shouldn't think of it as a diet. The way I eat now is not a diet. It's the way I choose to eat for the rest of my life, because I want to live a healthy and happy life and see my kids grow up.
Love it. So for those who ask you about the plant-based lifestyle now, because we get these questions all the time. I'm sure you do as well. There are documentaries, on all the streaming channels, and there are people out there who push plant-based diets for diabetes reversal and for blood sugar control. And they're very low fat, typically higher carb, not necessarily grains and things, but they'll focus on fruit and so forth. What is your feeling on that approach? I mean, you maybe you just explained it. You try different things and see what works best for you. But do you feel like that's a path that can work, or do you sort of discourage people from following the plant-based diet?
Yeah, people choose the foods they eat for a lot of reasons. It may be spiritual reasons, it may be religious reasons, it may be, whatever, that connect to the planet and all. And I believe that you can actually be very healthy or very unhealthy with any one of these diets in the spectrum, from full-on vegan to full-on carnivore. It's harder to be healthy as a vegan for the reasons I mentioned, just because, one, plant proteins are missing some key ingredients. Plants are not as nutrient dense as meat is. And second of all, not all, but most of the junk food is plant-based. I know, because I'm a former recovering junk food junkie. There are meat-based junk foods, but they're much, much less common.
That makes a lot of sense. So we talked a few minutes ago about imaging, and specifically around heart disease, vascular disease. But imaging can be really important for metabolic health, for insulin resistance, understanding some of the mechanisms of why you might be insulin resistant. We know that one of the things that drives up fasting blood sugar is insulin resistance in the liver. And one of the main causes of insulin resistance in the liver is that lipotoxicity, or having liver fat higher than optimal liver fat percentage. You're probably familiar with the work of Dr. Roy Taylor. We've had him on. He's done a lot of imaging studies in the process of diabetes reversal, and showed really a wide scale of liver fat percentage that seems to drive people into insulin resistance. So, for example, some people can have a relatively normal liver fat percentage, maybe in the single digits, but still be insulin resistant, while others can have a higher liver fat percentage and seem to tolerate it better. But there's definitely a threshold where things start to fall apart. Things start to, problems start to happen. But most people never look into this. They've never even heard of it, frankly, to have imaging done to check liver fat percentage, to check the health of their arteries, to evaluate their metabolic health or their some of the mechanisms that can drive poor metabolic health. So, can you talk a little bit about that and what maybe some of your recommendations might be if people want to do some imaging for some of these underlying mechanisms?
Yeah, I mean, just talking about liver fat, fatty liver disease, the type of fatty liver disease we're talking about is non-alcoholic fatty liver disease, which literally did not exist before 1980, except in people's kitchens as foie gras, which is fatty liver in geese and ducks, which was a food. But beginning in 1980, it began appearing in humans. To the point now in 2025, it's the number one cause of liver failure and liver transplants. It's eclipsed everything else. Most people don't know about it or are not aware of it. Even radiologists, because CT scanning, a type of X-ray we do frequently, actually measures the density of the liver, which corresponds literally to the percentage of liver fat. But radiologists don't measure it routinely, and they'll comment it on a report if it's obvious or gross. But the problem is the disease that changes when they're very subtle, unless you measure it, you won't pick it up. And radiologists don't measure it. So we wanted to change that. So we've developed the technology where we actually go in and measure it. And it's based on a 10-minute CT scan. And we measure the liver fat. And we report out liver percentages of liver fat that then you can act on. And it is reversible. Rob Lustig famously showed liver fat could be reversed in children with fatty liver by changing only the amount of fructose in their diet. He kept the diet, the calories the same, so it wasn't a weight loss thing, but he just substituted glucose for fructose, cut out the fructose, and within 6 weeks, he reduced the liver fat that was visible on imaging. So it's amazing how responsive this is, to programs like yours. That's where people should be in this with that. But anyway, so we do this 10-minute CT scan. We measure liver fat, first of all. And then we also do another important thing, which is bone mineral density. A lot of people go to a complete separate imaging for a DEXA type scan to get Z and T scores. Well, we can now do that from this quick 10-minute CT scan. And then on top of that, we look at the coronary arteries for what's called a coronary artery calcium score, which, a lot of blood tests and genetics and everything predict our risk of heart disease or our risk of one of these diseases. Well, the great thing about imaging, it doesn't show your risk of heart disease. It literally shows the disease there. If you have calcium, that's the disease. It's not like you're at risk for it, you have it. And that is a powerful motivating factor for people to actually get on a metabolically healthy program like yours, because even with calcifications in the arteries, we can stop it. We can keep it from progressing, and we can arrest it in its tracks, kind of like we do with diabetes. So these things are really, really powerful motivators for people. So these are now available. We're doing like a 10-minute scan. It's available anywhere in the U.S. It really, we're excited about what it's showing and helping people understand their metabolic risk. And then based on that, they could go in a program like yours and then change it and basically reverse those changes. Make the fatty liver disease, the fat percentage go down, stop the coronary arteries from calcifying, and if they have osteopenia or low bone density, they can actually raise that up through lifestyle interventions.
That's incredible, and I think so valuable. A lot of people are familiar with blood labs and asking their doctor for things like a fasting insulin, which I still don't understand why that's not done routinely, but it's not. But with the imaging, this is all new to a lot of people. So I think it's something to look into. We'll certainly put some information in the show notes about it. And if you're working with me, if you're in my sphere, this is something we're going to try to incorporate with a lot of our clients and patients because I think it is incredibly valuable. What's the main difference between a liver CT versus a liver MRI? Like, why would somebody want one versus the other?
Yeah, the CT scan literally measures density, electron density, like bone density, or so it's very good at that. And one of the things that varies in density is fat versus water. So CT is very good for measuring density. MR, magnetic resonance, on the other hand, is based on radio waves and magnetism. But you can also get density measurements from magnetic resonance imaging. It's a little more complicated, but you can in a nutshell, you can get similar results either from the CT or from the MR. What I like with this CT, it's the same CT scan that will give you not only liver fat, but DEXA, coronary artery calcium, arterial age, all these things at once in a very short time frame. It's about 10 minutes, low radiation dose. This can even be repeated every year if you want to see the improvements, to show that you're making progress with your lifestyle.
Does it give some of the body composition measurements like a DEXA scan would as well?
It gives a Z-score and a T-score, which are the markers for osteopenia and osteoporosis and the threshold. So it's based on, it's a very small amount of radiation right over your heart, really.
Right.
The DEXA scan radiates the whole body, which is a downside, but it also allows you to look at the hip versus the back versus so it looks at different areas.
I see. Okay.
We like this just because it's very streamlined. It's very narrow amount of field there.
Okay. One other question while I've got you is there's some people say that the calcium score is helpful but not perfect because it's measured calcified plaque as opposed to non-calcified plaque. And my understanding is that you would need to have like a CT angiogram to measure non-calcified plaque. Is that accurate, or what are the other things that people might consider doing? And I know that's probably not all that practical of a test to do, but can you maybe explain the differences between those?
Sure. There's two types of exams that we're talking about. First is a CT calcium score, which is the one that we're talking about. It's very low dose, low radiation. It takes about 10 minutes. It's for asymptomatic people, screening people. They feel fine, just want to assess them. The other one is called a CT angiogram, which is really for symptomatic patients. If you're having chest pain or other symptoms of heart disease, why don't we do that on everybody? Because the excuse me, the calcium score only shows calcifications in the arteries. The CTA shows the calcifications, but it also shows these things called soft plaques, which are plaques that haven't calcified yet. So why wouldn't you just want to do a CTA on everybody? Well, the problem is the CTA has a lot of radiation, like 10 to 15 times the amount of radiation as a calcium score, to the point where people are only recommending having these every 5 years just because of the radiation dose. But it gets worse. They also require an intravenous injection of contrast material, iodinated contrast material, which is really safe, but it's not 100% safe. What does that mean? Well, every year, a small percentage of patients, and it's relatively small, anywhere between 1 in 30,000 and 1 in 150,000 patients will die of a contrast reaction from getting that. Well, it's a small percentage, but guess what? if you die, it's 100%. And the great thing about the calcium score, the limited one, is there's zero chance of death. I mean, no one's died of a calcium scan unless there's an earthquake and the building collapses on you. So the point is, they're very different exams with very different risk profiles, and I wouldn't recommend a CTA unless you're symptomatic and you have a lot of reasons for doing it, and you're willing to accept the risk that is very different from a calcium score.
All right. That makes a lot of sense. Great information. This has been wonderful. Dr. Robert Lufkin, who has this book that I recommend you pick up. We just, barely scratched the surface. There's so much more in here. Lies I Taught in Medical School. So go to Amazon, pick that up, and I think it'll be a really good read. I'd love to talk some more. I know we're going to get back together here and talk about how to get the word out about this imaging so that people can have a look and see what their liver fat looks like, what their calcium score looks like. I think these are important functional tests. So thanks for being here. Thanks for taking the time with us here today on the Mastering Blood Sugar podcast.
Thanks a lot, Brian. It was really a pleasure.
Any parting words? Any last words of wisdom before we let you go?
Well, even though I'm a doctor, I now understand that doctors won't make me healthy. Doctors just make me less sick. If I want to be healthy as a patient, it's on me because it's lifestyle, and doctor can't do lifestyle for me. I get to do it myself. Every morning when I wake up, I decide what food I eat, whether I lift weights, whether I walk, whether I exercise, whatever I do. And that's very empowering, and I'm very excited by that.
I love it. Thanks again, Doc. Appreciate your time.
Thanks, Brian.